Okay, so I've just realised that the writing on my slides is not going to be visible to most people, so I'm going to have to read some of them. I'm delighted to be here, very excited to be invited to talk. I've often thought about how great it would be. I'm not sure who whispered in your ear to say that I should come. Maybe you might be sorry by the end of it. Open disclosure here, I've trained for 19 years before I became a consultant. I've been a consultant in James's Hospital for 13 years. I do spend half a day a week seeing private patients. I want to be upfront about that. I use my position to raise charitable money to improve the services to patients and my staff. I'm a father of 4 boys. I voted Labour and Greens all my life. I think we should be upfront about these political issues. I love to run, and I'm a sometimes Leeds United fan. So this is Joe. Joe is my dad. This is a picture of me on the left, roaring red hair, you wouldn't realise it now, and my brother on the right, and this is on the Lakes of Killarney about 1974. Joe died this year on March 2nd in a nursing home in Bunclody in Wexford, near his home. I couldn't get down to him, unfortunately, because it was the weekend of the massive snow. But I was in his house in Bunclody on the 17th of May the previous year when he fell over. Now, he'd been suffering from a long-term chronic disease. It's not important what type it was. In fact, it was a neurological disease, and it was a constant source of amazement to him that I couldn't cure him. But he fell over, and he never got up again. He had a urinary tract infection. We went into Wexford Hospital. He got treated with antibiotics. His acute care really lasted approximately a week. That's all he needed. But of course, he became a bit deconditioned in the hospital, and he wasn't able to go home immediately. And in fact, was not able to go to a rehab hospital, and got worse and worse and worse. And here he was sitting in a hospital bed in Wexford, the most expensive type of treatment that we can give our patients. And he lay there for 7 months. And then all he wanted to do was go home. That's all he wanted to do. And despite the most expensive treatment we're giving, we couldn't organise ourselves to create a situation where he could go home and get looked after by home help. They offered him 1 hour a day, which was totally inadequate. He was a very large man by the time he died. And then he went to a nursing home, which was, again, ironically, about a mile from his home, and all he wanted to do was go home. And then he died. And I genuinely think he died prematurely because of that. So I think at this point it's not unreasonable to maybe take a show of hands. And many people's disappointment in our health service extends to those kind of experiences. Anybody? Yeah. So a really good smattering of people have individual personal experiences of the health service which have disappointed them, have been personally terrible for them. So far, so we've heard already, our health system, is there anyone who can make it fit for purpose? The Irish health system is on the verge of collapse. These are real headlines. They're ripped from the headlines, as they say. We've chosen to have the second most expensive and one of the worst healthcare systems in the world. The HSE has no accountability, deliberately withholds information that could save lives out of fear of criticism. We've one of the most unequal health systems in the world. This is the winter our health system will finally collapse, and we need vastly more beds in the Irish health system to get rid of the trolley crisis. So far, so it goes along with our view, right? This is what we've heard tonight. So here's the problem. This is where the cognitive dissonance hits. This is a psychological term, which means when you face the evidence, you start to question your beliefs. So these things are what I would call material fallacies. They're not likely to occur. The most egregious one there is this winter, which was the winter of 2017, our health service will finally collapse. It clearly didn't collapse. This is probably the only word you can see at the back. I would consider these to be lies. I think the people who said these things knew they weren't true. But actually, our whole political media environment is peppered with these kind of catastrophic sayings. I go toe-to-toe with anybody on those individual statements, but probably more interesting is to look at what I call, so we've talked about lies, let's talk about half-truths. So the health system needs radical reform if it's to survive. Saying the health system needs reform is like saying grass needs water. Any health system that doesn't reform and constantly reform is not worth the paper it's written on. How radical is this reform going to be? I mean, are we really going to rearrange the upper echelons of the HSE again? I mean, really? We need reform, but there are very specific reforms that we require. And the word radical there, I would argue, is a total hyperbole. The system is top-heavy with overpaid managers, while those at the coalface struggle with poor resources. Again, the second half of that statement is true. We actually have very few managers compared to other systems. We have a tax-based system. So compared to, say, Germany and the United States, 1 in 2 workers in the health system in the United States is involved in financial management of health. It's an incredible number. And we're nowhere near that. It's like 1 in 7, 1 in 8. We have a system, we have actually a health service which is administered to within an inch of its life. If I rang tonight, one of my colleagues in James's Hospital and said, I need the MacGill School is moving to James's Hospital tomorrow, I need 500 chairs in the main hall by 9 o'clock in the morning. We'd get it done. That would happen. What we don't have are people who manage people. Nobody'd come up to me or Frank over 30 years as a consultant and say, you know, Colin, I'm concerned about your performance. I'm looking at these figures. The outcomes of your patients are not that good. Why can't you do better? We don't have that. And you can argue, we may get to why those management issues are not there. To make health more affordable, we need to move much care and substantial resources out of private care and acute hospitals into lower cost services, including mostly general practice. 100% agree again with the second half of that statement. And the decimation of general practice in this country is a tragedy. But taking 600 or 700 million euro out of the public health system and just paying it again with public resources, because that's what happens if you take private healthcare out of the hospitals. 600 million, think of what we could do. Susan mentioned 21 million. Think of what we could do with 600 million. And we're going to have to pay that in when we get rid of healthcare. Now, we can have a debate about what looks fair, the appearance of equity, all those questions. But if the question is quality in the public health system, there's no obvious link, in my view, to taking private healthcare out and improving quality in the health system. The HSE is a highly dysfunctional organisation that's beyond repair. Is it any more dysfunctional than any other organisation? That's what I would ask you. The political, the journalistic, the legal, the sporting. Is it really any more dysfunctional than those? And is it really beyond repair? I disagree. We can afford decent, fair health system for all. We have the money. No, we don't. We have the people. No, we don't. We don't remotely have enough people to do what we need to do. The question is, do we have the moral courage to do it? Well, the people I work with every day certainly have that moral courage. But we don't have the money and we don't have the people. So let me just show you some statistics. So we've got lies, half-truths, and statistics. Here's how the system's performing well. 84% of people, there is. 84% of people declare their health to be good or very good. That's the highest. In 2015, when all 28 EU countries were measured, that was the highest self-reported health in Europe, in the OECD. 84%. 75% of people eligible for breast cancer screening are screened. MRSA is reduced by 66%. Remember MRSA? MRSA was going to knock the health service off its feet. It was going to collapse. It was going to implode. And nobody had a plan how to fix the MRSA. Well, guess what? They fixed it. Antibiotics in the community are reducing. That's our GPs doing that work, reducing antibiotics and stopping the spread of MRSA. Here's stuff that I can take personal account for. 34% reduction mortality from stroke. 34% mortality. And a 51% mortality from cardiac arrest. And by the way, I know that we're behind a little bit on stroke. We're actually ahead of the OECD in heart attack mortality and ahead of the OECD in on-time hip fracture repair. Now, I'd like Kevin to give out a statistical package. So what I've got there is approximately 30 slides with all of the data in relation to OECD figures and comparisons. And you can reference that or use it. I'm not going to go through the data, but I'm using it because you may want to take me to task on some of these figures. Maybe Susan certainly wants to. Now, what does all that mean? What does all that mean? It means, you know what? It's all working really well. We don't need to do anything. We can all lie back. It's all working well. Here's where we're really not performing. 56% of patients go home and they don't know what medication they're taking. It's a remarkable figure. Younger patients are much less satisfied with their care than older patients. Antibiotic usage, unfortunately, in hospitals still remains high. Immunization rates are very poor, and there's other reasons, as you know, in society for the fall off in vaccination, which are not particularly to do with the health service. We only screen 40% of our patients for colon cancer, which explains why our colon rates are low. And we still have a high rate of caesarean section. So, you won't be able to read this, unfortunately. Here's a summary, and it's all in those documents. We are outperforming the OECD on 9 of 13 important health indicators. Let's say that again. We are outperforming the OECD group on 9 of, and these are not, I'm not talking about minor things like ingrown toenail repair. I'm talking about under 5 mortality, maternal mortality, longevity, suicide rates, preventable and amenable diseases. And in terms of cancer, yeah, we have an issue about cancer, but we're very near the averages for the top 3, cervical, breast, and colon, and we're better than the average for rectal. We're on target or have surpassed, by the way, of the 4 that we're not hitting targets for OECD, 2 of those are our alcohol and drug intake. And again, you can't lay that completely at the feet of the health system. We know we have cultural reasons why our alcohol intake. And by the way, since 2008, we've had dramatic drops in those, although we still remain high. We're on target or have surpassed 7 of the 9 measures of the WHO Millennium Development Goals. The only 2 we haven't reached are, we haven't halved our maternal mortality, and that's because we had the best to start with. And the other one is, we haven't halved the number of people who don't have access to clean water, which is really not a relevant statistic for the Irish health system. We have the highest self-perceived health status among the EU, which I gave you that figure already. Now, here's where we're below the OECD average. We're below the OECD average in terms of staff, and this dropped below Greece in 2010, and it's only starting to recover. We do not have the staff to deliver. And in fact, when you marry the number of staff we have with these health indicators, there's actually a pattern emerging where we may actually have, in relative terms, the best health system in the world. We're doing all these things with much less staff than anyone else in the world is doing it. Now, let's talk about the most visible, apparently intractable performance issues: wait times and patient safety incidents. I'm going to leave that hanging for a minute because I want to talk about what I think are invisible, intractable health systems which are never really mentioned, and that's the issue of the health of our long-term homeless population. So a man who's homeless has a life expectancy 30 years below his equivalent. 30 years below his equivalent male. Now that is a health scandal of enormous proportion, and I've never seen a headline in a newspaper about it. These wait times and access, they're the scourge of all modern health systems, okay? They're highly politicized, and the solutions are not mysterious. So let me give you 2 examples. If you went home tonight and you said, my garden's a real mess, I'm going to get a gardener in tomorrow to fix it. The gardener came in and you said, the gardener, how much do you think this is going to cost? Well, I think it's going to cost €150. And you gave him €150 and left him to it. You would never do that. You would wait until he'd finished the job, and then you would pay him. And you wouldn't pay him if he did a terrible job. And you wouldn't pay him until he had finished, which gives him an incentive to actually finish. Now, the funding, the resource allocation model of the Irish health system is everything's funded up front. James's Hospital gets $320 million at the beginning of the year, and it's told, do what you like with that. You need to fund outcomes. You need to say, here's a patient who had epilepsy, was admitted to your hospital. What happened to them? Oh, they only spent 3 days in hospital, and you got them into an outpatient clinic very early, and you got their scans done. We're going to pay you top dollar for that. Now, that's a reform I can live with. And it doesn't involve firing all the so-called millions of managers in the HSE. And by the way, the people who have control on that are the Department of Finance, or nothing to do with the HSE. The people who make these decisions, I sat in a corporate meeting with Finance and HSE and said, you need to change the resource allocation model, and you need to give financing control to people like me, because I know where I can save money, and they laughed at me. They laughed at me. They were never going to do that. More beds, solution to the ED, provably incorrect. I'll have a work example in the system there. If we move to a 7-day system, which needs, by the way, 30% more staff, but if we move to a 7-day system, we would have a bed occupancy of 93%. Now, there are loads of other solutions to the trolley crisis, but that's it. And why is it so politicised? I don't know. Why is it so politicised? Why is it that the nursing union has control of the data? They call it trolley-gar. Why would you cede control of the data to a union? By the way, we cannot compare our figures. Here we are comparing OECD figures. We cannot compare our figures to the rest of Europe because nobody else uses this data. Everybody uses 4, 6 and 12-hour waits. What should we do now? This is my last slide. Is that it? Yeah, I turned it off myself. Self-censorship. I would like, if you could celebrate, just for how long it takes to read this statement, the work done to reach and surpass OECD and EU averages for basic health statistics. Right. Don't do any more. No more celebrating those stats. Some of the best in the world. I want you now to continue to demand that the health service reform and improve. Because we get motivated by that. Now, the fact that there's never any praise for the statistics, that may be an issue. You may want to reflect on that. But don't do any more celebrating. Bring, as a matter of urgency, the patient voice into the planning, design, and delivery of services. It's so important that you guys and citizens understand just how complex healthcare is, and the only way to do that is to get people into the ground floor and have them understand it. Train and encourage a culture of open disclosure, the emphasis on training. You cannot just have open disclosure without training people how to do it. Please stop reorganising the upper echelons of healthcare. Please don't get rid of the HSE. I'm begging you, if anybody out there has the capacity not to do this. Accountability, I'm going to leave that because I'm running out of time. But I got that definition from NASA. Don't try to boil the ocean. The Sláinte Care has a lot to recommend it. It's cross-party, it's non-political, it has all those things, it says all the right things about integrated care, but it's a massive project. And there are specific things that we need to do. And I just wonder if we're going to get these things done if we boil the ocean of Sláinte Care. And it's built on the notion of all those material fallacies at the beginning. Everybody says, of course we have to completely reorganise everything, get rid of the HSE, because look how bad everything is. Actually, you know what? Maybe it's not got that bad. Uncover the real scandals of our health system. Life expectancy, a long-term homeless male, 30 years below his homed partner. Stop the beds madness. Don't put a penny more into a new bed until we are using all the beds we have properly. And promote love and compassion as enabling concepts in healthcare. These are the reasons that people like me and young people go into healthcare all the time, because they are filled with those kind of enabling concepts. And what happens is, every time chunks are taken out of the health service, nobody in this room, I guarantee you nobody in this room, is as frustrated and as annoyed when something bad happens in the health service as I am. But the fact that there's nobody out there advocating, why would you go into this care system? Somebody said the other day on social media that the HSE was a sinister organisation that promoted death. Now, how are we going to get young, positive people filled with love and compassion into the health system with that kind of language? Okay, my final point, 2 things. Joe, go back to Joe. Everything I said about Joe at the beginning and all the frustration I had with not getting him home was true. But you would not believe the care that he got in Wexford Hospital. I will not hear a bad word said against smaller hospitals after my experience. They were fantastic, and you can quote me on that. I pay tribute to the medical team in Wexford Hospital. They were brilliant, and they knew that he didn't want to be there, and they did everything in their power to make it as comfortable as possible to him. It was just an amazing experience of healthcare. And all this idea, let's get rid of all these smaller hospitals. Not a chance. These smaller hospitals are where good care is happening. My final point, I'd like you all to close your eyes. Go on, just bear with me. Some of you have already gone off me, I know, from what I've said. So an American philosopher called John Rawls, he died in 2002. He was from the liberal tradition. He came up with a concept that he called the veil of ignorance. And what his idea was in the veil of ignorance was that if you were planning into society, you would ask the planners to wear the veil of ignorance. In other words, they would not be able to decide where they would be born, what sex they were, what race they were. And if you had that veil of ignorance, what kind of society would you create? And it was an interesting thought experiment because it would mean you would try to create the most equal society you could possibly do. Now let me just do a little slight variation on that. If you close your eyes now and use the veil of ignorance, now, you have a choice to be born any time in history up to 12 o'clock tonight. You have no choice about where you be born. You have no choice about what sex you would be. You have no choice about race you would be. I put it to you that if you look at the data, you would be damn sign better off by being born in Ireland at 11:59 tonight. That's if you believe in the data. Thank you.